Okay, let's dive right in and map out one of the absolute most complex and honestly fascinating structures inside your head. Welcome to today's Explainer. We're taking a deep dive into human anatomy to explore the biological wiring that literally allows you to chew your food, feel the cold wind on your chin, and, yeah, unfortunately, experience that super unpleasant sensation of a dental drill. We're talking, of course, about the mandibular nerve.
But before we get bogged down in all the heavy anatomical terminology, let's start with a question you've probably asked yourself at like 2 a.m. on a Tuesday. Why does a bad toothache sometimes make your ear throb? It's a total mystery many of us have felt, and the answer is actually hidden inside a biological transit system we're exploring today. By the end of this explainer, that bizarre little quirk of the human body is going to make perfect sense.
To get there, we really need to define exactly what we're dealing with. The mandibular nerve, or cranial nerve V3 if we're being official, is basically the major neural highway of your lower face. It's the absolute largest of the three divisions of the trigeminal nerve. And crucially, it's a mixed nerve. That means it carries both motor fibers, which are the signals telling your muscles to move, and sensory fibers, the signals telling your brain what you're actually feeling. It's the primary nerve of the first pharyngeal arch, which is just a fancy way of saying it does the heavy lifting when it comes to mastication, or chewing.
Because this anatomy is incredibly dense, here's our quick roadmap for today's journey, running from the brain straight down to the jaw. We'll start with the ultimate facial highway, trace the main trunk, explore the anterior and posterior divisions, and finally, check out the clinical impact, specifically how dentists use this exact map for pain relief.
All right, Section 1, the ultimate facial highway. Let's start right at the source and see how this incredible network begins inside the skull.
Picture that massive trigeminal ganglion breaking off into three distinct branches. That thick bottommost branch heading downward, that's our target, the mandibular division. It's leaving the middle cranial fossa, totally prepping to branch out and bring life to the lower third of your face.
But it doesn't just start as a single cord. The nerve actually begins as two distinct roots. First up, there's a really large sensory root arising from the convex part of that trigeminal ganglion. Second, there's a smaller motor root that originates a bit deeper, coming straight from the pons in the brainstem. Much like two rivers merging, these roots travel together and combine immediately below the skull's exit door, a crucial anatomical landmark called the foramen ovale. Once they slip through that opening into the infratemporal fossa, they fuse together into a short, incredibly powerful main trunk.
Which brings us to Section 2, the main trunk. Time to check out the first exits on our anatomical roadmap.
Right out of the gate, before this highway splits into its major divisions, a couple of super important offshoots take their exit right from this short main trunk. First, we've got the nervus spinosus, a meningeal branch. What's wild about this one is that it takes a recurrent course. It literally does a U-turn, goes back up into the cranial cavity through the foramen spinosum, and supplies sensory feeling to the dura mater, the tough outer covering of your brain. The second branch is the nerve to the medial pterygoid. This one is purely motor and goes straight to power one of your essential chewing muscles. So right from the very start, we've got sensory signals heading back up to the brain's covering and motor signals heading down to power your jaw.
Right after that short trunk, the nerve splits into a small anterior division and a large posterior division. Now, there is a beautiful bit of anatomical symmetry here that acts like a cheat code for memorizing the whole network. We call it the rule and exception. The anterior division is almost entirely motor, with just one single sensory exception, the buccal nerve. On the flip side, the posterior division is almost entirely sensory, with one single motor exception, the nerve to the mylohyoid. If you lock in that cross-wired symmetry, you've basically unlocked the fundamental logic of the entire mandibular nerve.
Okay, moving to Section 3, the anterior division. Think of this as the motorway for chewing. These anterior branches are heavily focused on movement. You've got the masseteric nerve powering the masseter muscle, the deep temporal nerve supplying the temporalis muscle, and the nerve to the lateral pterygoid doing exactly what its name implies. These are your primary muscles of mastication. They're what allow you to bite down, grind, and talk. But remember the buccal nerve? True to our rule, this is our lone sensory scout. It runs right onto the buccinator muscle but doesn't actually make it move. Instead, it provides sensory feeling to the skin of your cheek and the mucous membranes inside your mouth.
All right, Section 4, the posterior division. We're taking the larger fork in the road now, diving into the sensory route for your teeth, tongue, and ear.
This is where we map out the pathways responsible for feeling in your tongue, teeth, and the side of your head.
We have the auriculotemporal nerve, sweeping backward to supply the ear, the temple, and the temporomandibular joint. Then there's the lingual nerve, giving sensation to the floor of your mouth and the front 2/3 of your tongue. And finally, the big one, the inferior alveolar nerve. It's the largest branch, and it gives feeling to your lower teeth, your chin, and your lower lip. Think of that massive inferior alveolar nerve like a literal heavy-duty cable dropping straight down into the jawbone itself. It enters through a hole called the mandibular foramen. Once it's safely inside the bone, it runs right through the mandibular canal, dropping off all these little sensory branches to every single one of your lower molars and premolars.
But wait, remember our rule. The posterior division is all sensory, except for one branch. Right before that thick inferior alveolar nerve enters the jawbone, it drops off a single motor branch, the nerve to the mylohyoid. It pierces right through the surrounding ligaments, traveling down a small groove on the bone to supply movement to the mylohyoid muscle and the anterior belly of the digastric muscle. It perfectly fulfills that earlier rule. Anatomy really rarely leaves loose ends, does it?
So moving to Section 5, clinical impact. We've mapped the highway, but why does all this dense anatomical knowledge actually matter to you the next time you're sitting in a dentist chair? Well, when you go in and get a lower cavity filled, your dentist uses this exact roadmap to deliver what's called an inferior alveolar nerve block. It's actually the most common nerve block in all of dentistry. To stop you from feeling the drill on a lower tooth, they don't just inject the tooth itself. Instead, they aim for the trunk of the nerve right before it enters the bone. They use a specific bony landmark called the lingula, which kind of overhangs the mandibular foramen. By injecting the anesthetic slightly above that entry point, they freeze the entire neural highway downstream. Your teeth, your chin, your lower lip, they all go completely numb because the signal has been blocked right at the gate.
But here's where knowing this highway becomes absolutely critical. Anatomy requires precision. Why? Well, right behind this injection site lies the parotid gland, and running right through that gland is a totally different cranial nerve, the facial nerve. If a dentist overshoots the mark, inserting the needle just a bit too far posteriorly, the anesthetic seeps into the parotid gland and blocks that facial nerve. The result? Transient facial palsy. Literally half of the patient's face will temporarily droop and be paralyzed until the drug wears off. That is the sheer power, and honestly, the danger of navigating the body's internal wiring.
And finally, this brilliantly solves our initial 2 a.m. mystery. Remember that toothache making your ear throb? The source material describes a phenomenon known as referred pain, because your lower teeth are wired by the inferior alveolar nerve and your ear and temple are wired by the auriculotemporal nerve, and because both of those nerves merge back into the exact same main posterior trunk, your brain actually gets confused. When severe pain travels up the inferior alveolar branch from a bad tooth, the brain misinterprets where that distress signal came from. It refers the pain along the shared highway, sending it straight to your ear via the auriculotemporal nerve. It's literally an anatomical crosstalk error.
It really makes you step back and appreciate the incredibly interconnected wiring of your own face, doesn't it? The mandibular nerve isn't just a boring textbook diagram. It's a living, breathing transit system that lets you interact with the world and experience your own body. Which kind of leaves us to wonder, if a single nerve network connects our chewing muscles, our teeth, and the sensation in our ears, what other anatomical marvels are hiding just beneath the surface? Thank you so much for exploring the mandibular highway with me today. Keep questioning, keep learning, and I'll catch you next time.